All right, so hello and welcome to our national TB call. For all of those who are new to the network, the purpose of these calls is to bring together everyone working on TB in Canada for an informal discussion to share information and coordinate our efforts. So before I begin, my name is Lee Racy and I'm a Policy and Advocacy Officer at Results Canada, where my work focuses on the fight to end tuberculosis at home and abroad. And I'm also a member of Stop TB Canada, which is a continuing to grow network. And if you have not yet joined our directory, I would encourage you to fill out the Google form that Lena will share in the chat. So these calls are intended to just be an informal discussion among peers. So to kickstart, it would be great to just know who we have on the call. So feel free to introduce yourselves in the chat. In terms of our agenda for today, we'll start with a brief report back from the Stop TB Canada Secretariat on our recent progress. We'll open the floor to hear from others in the network on their recent work, as well as a discussion for anyone on the call to share ideas on how we can collaborate as a network moving forward. And I'll close the call by briefly outlining some upcoming activities that the wider network is encouraged to join. So since our last national call back in May, we've been really busy continuing to build the network and engage with the broader TB community. So I'll start by highlighting a couple of our key projects and priorities of the last couple months. We published our annual report back in April, which outlines our progress from March 2020 to March 2021, where the focus was really just to reinvigorate the network. We wrote op-eds for the Globe and Mail, a health affairs blog. A couple members of our steering committee got published in the Journal of Clinical Tuberculosis. And we published our first joint publication as a network, which is the TB fact sheet. So I'll just share that really quick. So this resource is intended to be a comprehensive fact sheet on everything TB, as well as an advocacy tool specific to Canada on what must be done to meet domestic and global TB elimination targets. So these calls to action that we've included have really been driving our advocacy in terms of what we bring to meetings with MPs, ministers, and other decision makers. So in terms of domestic calls to action, we've included updating the epidemiological data on TB in Canada, assessing the impact of COVID-19 on TB. Sorry, I'll just go to the right page. And on that point, Lena will talk to that a bit later in the call on what Stop TB Canada has been doing to assess the impact of COVID on TB in Canada. Another priority is addressing the health inequities with respect to newcomer and Indigenous health, and incentivizing the registration of child-friendly TB drug formulations in Canada. In terms of our global calls to action, these include supporting the global plan to end TB, meeting the TB research funding target that Canada committed to at the UN high-level meeting on TB in 2018, and renewing financial support for initiatives such as TB Reach, which are even more crucial now in the context of COVID-19. So we'll share that resource in the chat as well. So feel free to use it and share it with your network as well. Okay. Our network also submitted a couple of different sessions to upcoming conferences this quarter, so including the Union Conference and the Canadian Conference on Global Health. Both of our submissions to the Canadian conference were recently accepted, and we'll have a couple of our Stop TB Canada Steering Committee members as speakers. With an election around the corner, Stop TB Canada recently submitted to the pre-budget consultation in advance of the upcoming federal budget. So we recommended to the government to fund and implement a robust, modern, timely national TB surveillance infrastructure in collaboration with provinces and territories, as well as fund and support the ongoing work of the Pan-Canadian Health Strategy. So we'll share the link to the submission in the chat for those of you who are interested in reading the full submission. Stop TB Canada has also been focused on bringing the TB and HIV communities together to increase our impact, recognizing that TB and HIV are so interconnected in many ways, yet TB and HIV work often operates in silos. So with this in mind, we held a webinar last month in partnership with CAN and ICAD to have a conversation around the intersections of TB and HIV, how both diseases have been impacted by COVID, and what opportunities exist to streamline our advocacy efforts going forward. So we'll share the link to that webinar in the chat as well for those of you who are interested. And one thing that came out of this webinar was a call to participants to join a TB HIV working group to drive forward our joint advocacy in the lead up to the International AIDS Conference that's actually happening in Canada in Montreal next summer. So if anyone on this call would be interested in joining that group, please reach out. We'll share the email for Stop TB Canada and I'll be in touch. Another initiative that we are prioritizing is building a community for those affected by TB in Canada, led by our wonderful steering committee member, Priya. So far, we have a Facebook page that was just launched, and we've created this flyer that is being shared at TB clinics in an effort to grow the group and provide a safe space for those affected by TB, TB survivors, their friends and family to connect, share resources, and just provide support for one another. So please feel free to join the Facebook group, share it with your network. We would also encourage anyone on the call who works closely in TB clinics to print off the flyer and share it with your local clinic. We really think that this community could have a meaningful difference for Canadians affected by TB. So any support in promoting the group would be amazing. And lastly, our network has been working hard to assess the impact of COVID-19 on TB programs in Canada. So I will pass it over to Lena to briefly describe the project, where we're at, and how we hope to disseminate and use the findings in our advocacy.
Hi, everyone. Thanks, Lee. So so within our network, we had anecdotal evidence of diagnostic delays due to COVID-19 and people presenting with more severe disease in TB programs. So as a result of that, we wanted to assess the impact that COVID disruptions have had on TB services in Canada. So Stop TB Canada conducted a survey of program leads and program staff. And we're currently finalizing the report of this survey to, hold on, sorry, I'm just in the library, so. Yep, so we're currently finalizing the report of these findings, which we hope to share at an upcoming webinar in September. And we hope to use this as a tool for advocacy to call for mitigating the impacts of COVID-19 on TB care. Thanks.
Thanks, Lena. So yeah, we'll definitely keep the group updated in terms of when this webinar will be happening, where we'll be sharing our findings. So that was an overview of what Stop TB Canada has been working on recently. And now we would love to hear from all of you on your recent work. So I will pass it over to Dr. Elizabeth Ray to open up a discussion around recent TB work in Canada.
Thanks. So I have one short thing and one longer thing, which is going to bump to somebody else on the call. So the shorter thing is just to flag, I was going to say a really fun piece of research. I think it's fun. And this has two pieces to it. So some of you may have heard of TB Reach, which is an international funding stream for innovative approaches to TB detection and care in the hardest to reach parts of the world. So it tends to be very, rural, poorer areas, more remote areas, working on that kind of thing. And a lot of the funding for TB Reach comes from Canada. And TB Reach project was just published looking at the use of computer-assisted chest X-ray diagnosis. in Bangladesh, and which is super cool, because what it can mean for more remote areas is, if you have the machine, you may not need like a qualified radiologist to look at every single chest X-ray, which is pretty hard to come by in most parts of the world. So what this study did is look at 5 different computer-assisted chest X-ray diagnostic platforms, and compared them to TB diagnoses made by GeneXpert, which is kind of a rapid diagnosis tool that also doesn't need a full-blown TB lab. For those of you who are familiar with the PCR tests for COVID, it's a little bit similar to that, but kind of highly automated, so that you don't actually need to be a full-on lab technician to make it work. Anyway, so what it found was, I'm reading off the summary of the report that was just published. All 5 algorithms reduced the number of GeneXpert tests required by 50%, while maintaining a sensitivity for diagnosis of TB above 90%, which is pretty dramatic. So I just wanted to mention that, because it's a really nice piece of Canada contributing pretty directly to something that could make a big difference for people with TB around the world. So the other piece that I wanted to really introduce is a project that happened here in Toronto, and like, big disclaimer, I was part of that project, around TB and stigma, and how we can better recognize that and kind of harness those learnings to have better access to TB diagnosis and care for people, specifically in Toronto, but I really think it's much more broadly applicable than Toronto per se. So Cliff, do you want to introduce yourself and talk a little bit about the project? And then we're hoping that we could have a bit of discussion around the table, what other people think about it, what your experiences might be around TB stigma. So Cliff.
Hi, thanks, Elizabeth. So I'm Cliff. I'm the Associate Executive Director at Access Alliance Multicultural Health and Community Services. We are a large community health center located in Toronto. Our mandate is to provide services, primary care and related community services to immigrants and refugees who live in the city of Toronto. That's our total mandate. And we also do a lot of provision of service to smaller groups within that. So LGBTQ, youth, women, seniors. And we have a lot of focus on first and second generation Canadian born people who strongly still identify with their immigrant and refugee roots as well. We applied for PHEC funding a couple of years back, and we were awarded a project to take a look at TB care in Toronto, focusing on larger immigrant and refugee groups who come into Toronto. We chose the Chinese, Indian, and Filipino communities because they represent 3 of the largest immigrant and refugee groups coming into Toronto, who also have a high degree of tuberculosis as well. So those are the 3 communities. We set up specific work groups with each of those communities to do to get a better understanding of the impact of TB on their communities, as they come into Canada, what are some of the issues that they're dealing with, that they're facing in relation to TB, both potentially in their home country and as they're coming into Canada, and then as they're settling into Canada. We had an advisory committee. Elizabeth was part of that advisory committee and extremely helpful in her role on that committee. A number of other agencies were also there, settlement service agencies, a couple of community health centers, Toronto Public Library, for example, was there. Some organizations who focus on sort of thinking outside of the box as a part of their mandate when it comes to looking at how we can better provide care and support to systemically vulnerable populations. One of the criteria that PHAC gave us is that yes, we would focus on Toronto, but anything that we came up with should also apply at a national level. And we believe that in the report that we produced and the 4 fact sheets that were also produced with the report, that they certainly fit the Toronto landscape, but we did make sure that in those recommendations that there would absolutely be applicability across the country, specifically in relation to the resources that would be needed if some of the recommendations were to be implemented. Stigma wasn't initially wasn't the goal in terms of it being a focus, but it rapidly became apparent that if we didn't pay attention to stigma and to the stigmatization that can happen to people and that happens to people in a number of different ways, that we would miss the boat in terms of the pieces that we looked at. You know, by the end of the report, it became very apparent to us that in many ways, stigma is actually the disease that we need to be paying attention to, and that it is actually a disease in and of itself. It's a social disease, and that if we don't look at stigma, then we, from a clinical point of view, from a medical point of view, we will not be able to properly support people in achieving better health. And Lee, it was interesting that as you very quickly sort of flipped through some of the recommendation calls to action in that report, I was able to see, for example, that you are making a comparison between TB and HIV, and that also for our report very quickly became apparent. It's no surprise, I'm sure, to all of the people on this call that there are certain illnesses, certain diseases that get tagged to very small portions of the population, and that when that happens, that because of stigma, there is less support provided to those medical issues. There is less attention paid to those medical issues because within that community, like the LGBTQ community, the addictions community, there is stigma that is attached to it. People can very easily say this isn't something that affects us as a whole, which often means white, middle class, upper middle class people. They feel unaffected by those particular medical conditions, and because of that, pay less attention to it. So stigma certainly came out loud and clear as a disease that we would need to address if we're going to properly support clinical conditions like tuberculosis or like HIV. We also suggested in the report, or are recommending in the report, that when we're looking at clinical issues like TB, that TB needs to be housed in the larger provision of care around primary care. That it's best looked after, paid attention to, if it fits into a primary care envelope. In primary care, we're asked to care for people in a holistic way, and when we can approach people in a holistic way, we can often deal with stigma, we can deal with the particular illness, and we can deal with any of the other issues that may be affecting that person, like housing, like education, like language. We can look at all of those barriers to health and look at the person as a whole. And tuberculosis is one of those areas that we can pay attention to, but within a model of care that looks after other conditions or barriers that may affect a person's life. When we think about primary care, though, there are models of primary care and ways of doing primary care: team-based primary care, interprofessional team-based primary care, where if we're practicing in that model, we can pay very good attention to people and look after them through the eyes of a number of different professions. So at Access Alliance, for example, I mean, we have doctors, nurses, we have nurse practitioners, social workers, counselor therapists, health promotion workers, a whole team of people. And so when we think about somebody who is TB positive, for example, and is taking their medications, if they need additional support, they can get in contact with a nurse, they can get in contact with a health promoter. We can offer groups to people where they can be experiencing their TB care as a group, and there can be peer support that is available to them. So not only primary care, but team-based primary care in terms of our report presents an ideal place where we can be looking after various clinical illnesses. The other area that we looked at is that there needs to be that same kind of interconnectedness when we think about public health and primary care, when we think about settlement. Those are three major sectors where there must be really strong communication, really strong connections, so that if public health is identifying somebody that is has latent TB, and they want to get them into care, that they would immediately be able to place them into a primary care setting where they would be able to work with the doctor, work with the team to get them into their medications and be able to support them through that entire process. If somebody is an incoming newcomer to Canada and they're working with the settlement agency and tuberculosis comes up, if that settlement worker can very rapidly get them into primary care, they're going to get a much better level of care and support. And TB may be one of the things that needs to be addressed, as can a range of medical conditions or illnesses then be addressed, because that person is directly connected to primary care. And those connections need to be really easy, very rapid. They need to be as easy as one telephone call, and that when that happens, settlement can do its work, public health can do its work, and primary care can be involved in its work. Again, connecting people to specialists, if that is the case, because primary care is the gateway to many specialist services in the Canadian healthcare system. So those were three of the very large recommendations that came through in our report. There are numerous smaller related recommendations that are a part of the report. I don't know, Lee, if we've been able to have we been able to send out the report, or is that something that we can do?
Yes, we have shared the report in the chat.
Okay, so that's great. So I mean, people can certainly take a look at the report. You can take a look at the fact sheets. The report and the fact sheets are available in both official languages, so English or French. And we have some supporting documents related to TB care that are also available in multiple languages, and those are available through riomix.ca. You can go to that website and pull additional resources in English, French, and multiple languages from that website as well. Elizabeth, over to you. Are there any specific things that you would like me to highlight out of the report, or a little bit more information about how the process looked?
Maybe let's open it up at this point, because I'm pretty sure other people are going to flag issues that this project ran into as well.
Sure.
So broadly speaking, like I recognize some of the names. So I know some of you are working in more Indigenous health and with FNIB, and other people coming from different kind of backgrounds. So anybody else have I guess specific thought, like what's your experience with TB stigma with the people that you work with or the communities that you work with?
Yeah, can I add one thing in just
Yeah, sure.
before we go, that I noticed in the report that that your group worked on in terms of eradicating TB in Canada? I think you said by 2030. I mean, one of the things that you know, as an agency that provides services to immigrants and refugees, I mean, one of the things that we would need to keep in mind is that, you know, immigrants and refugees are in a constant interaction with Canada and are coming in year after year. Yes. And so a little bit of thinking about what does that eradication piece look like as new people are coming into the country on an annual basis. So something that speaks to, you know, the eradication of TB for people who are resident in Canada, also keeping in mind that there is an annual influx of people coming in from various parts of the world where TB is quite prevalent.
Yeah. It's not a once and done thing. Not until TB is eliminated in the whole world. Sure. Yeah. So what it needs to be sustainable within the healthcare and public health systems and all of that. Does anybody else see TB stigma as an issue where you're working?
Can I also add in another little snippet? So when we looked at stigma, we looked at it directly in relation to if somebody is a newcomer coming into Canada, they face some stigma just as a newcomer potentially coming into Canada. We looked at intersections as well. So people who are coming from various parts of the world may face stigma just because they're coming from various parts of the world. There may be racial issues, language issues, income, class are some of the intersections that we also connected to tuberculosis. So the stigma may in fact be directly related to a person having TB. It may also relate to other parts of that person's life. Yeah. As a newcomer, again, it may be racialized stigma. It could be cultural. It could be about the language that the person speaks. We looked at the impact of stigma on the relationships between the people providing care and the people, a person receiving care. So there were intersections within that were incredibly important as well. Many layers of what stigma can look like, not just in relation to a person actually having TB.
Mm-hmm.
Yeah.
Cynthia, can I maybe pick on you, because I know you're coming at it from the Indigenous First Nations side. Is that something that you see as an issue for the folks you work with as well?
Yes, and hi, my name is Cynthia. I just put on my video feed. Sorry, my camera might be a little bit darkened, but thank you, and I'm glad to be participating in this little conference here. I love picking up little tidbits of information. Just to answer your question on stigma and what I've experienced as a primary healthcare provider in the past was with reference to our Indigenous populations in isolated communities where without breaching that confidentiality of which community and which family members, there was an active latent case where it was traced back through contact tracing back to a young adolescent who may have contracted it from his late grandfather. So that's where I was trying to remember back. And what I felt though at the very beginning was a lot of positive support when I was on the front lines, where we had a designated TB team out of Suligout Hospital, and that's Minoyawan. The two gals that were nurses there guided us through every little step, from the treatment, the screening, the Manitou tests, how to do the contract tracing, where it kind of like went like to a little, how do you say, it involved numerous peoples, because like when you think of our social determinants of health, where there's a lot of overcrowding, housing issues, and those issues that we also have to deal with. And I knew our CD team was really wonderful, and I know they're on the call also too, and they were people that I could access. And one point I always found in relation to like the disease itself was community members needed to be taught, informed of what to do, how to get tested, and relieve those worries and that stigma of being diagnosed with TB. Also, from a colleague perspective, I would have to train my other colleagues to say, okay, we still can don our PPE. We still have to interact and to actually feel comfortable with it within our own practices. Just one more small side little comment I wanted to say. My father, who is 76 now, was diagnosed with active TB when I was 5 years old. And back then they used to have sanatoriums. Mm-hmm. So here in Thunder Bay, he was put in the sanatorium for 6 months. So, and I remember that we weren't able to interact with him for 6 months while he was on his treatment. So that is like huge steps in now how healthcare has changed. So I thank you.
I just wanted to add to that, this is Courtney speaking, that we see a lot of people, community partners, who want to talk openly about TB and don't necessarily have an audience or a platform, and are so used to having insights and their voices silenced over time. So it's not necessarily that the TB itself is stigmatizing, it's that there is just a longer history of exclusion kind of writ large in Indigenous communities from participating in health and wellness goals. And kind of paired with that is the fact that programs at the provincial level will come extract data from a community and kind of report it at a larger level that kind of obfuscates what a local solution might be. So there's not a lot of local input on solutions. And so there's sort of this history of neglecting insight, but also not optimizing solutions. So I don't know what you see a lot of that U-shaped curve of concern in TB, where there's a reactive response to a crisis. The clinical solutions get pulled out once the incidence drops, but there isn't sustained effort to address the social determinants that allow the incidence to go back up as soon as you have new infectious cases replenishing a reservoir of LTBI. So, so I totally agree. It's both yes and no about TB stigma where I work and what I've seen.
And just for context, Courtney's in Alberta.
Yeah, sorry, that's in Alberta, and working in Treaty 8 territory in Saskatchewan and Alberta.
One of the things that we heard, well, so it's sort of two comments I just wanted to pick up on, I think it was Cynthia, around, you know, so, and this certainly relates to some of the discussion that you may be having on TB and COVID, in the work that we've been supporting for COVID. I mean, one of the things that we often hear is, you know, well, just isolate. We work with just isolate, like you've got COVID, just isolate, like, you know, just stay at home and isolate. And we work with a lot of families who are low income families, and there may be 5 or 6 people living in a 1 or a 2 bedroom, you know, tiny little apartment. And when people just sort of say things like, well, you know, just isolate, they're not taking into account income and housing and those pieces. And we heard similar types of things in comments when it came to TB, you know, for example, so like, you know, just like, you know, you may just need to isolate, but that can be really difficult if you, you know, for many people to be able to do. So those kinds of comments that come with a particular context that fall out of people's mouths who live in a particular context aren't necessarily paying attention to not everybody's life looks like that, and we need to be thinking about those kinds of things. The other thing that we heard from our three cultural groups as we were working with them and co-designing some of the co-designing the recommendations is that some of the stigma that they often face in Canada is from within their own communities as well. And so there are barriers and challenges that come from the home country that come with a community to Canada, in particular around income and class. That if you have TB, it's because you are poor. If you have TB, it's because you're from a lower class. And so in Canada, part of the experience that is felt within those cultural groups is, if I disclose that I have TB, I now face stigma in relation to my income level. I face stigma in relation to class. And that's also part of the reason, that's also part of when I come to Canada, I don't want to have those things impact me. I'm coming to Canada potentially for a new start. I'm coming because I want my children to have an experience that they may not have been able to have. And that by declaring TB, by letting people know, even by asking questions about TB or participating in education around TB, I may be opening myself up to criticism, to stigma from within my community here in Canada. And that came out a number of times in the focus groups that we did with all 3 of the cultural groups. The other thing that we certainly heard is that from Canadians born in Canada, many were, and we did a few interviews on the street, for example, many people were surprised to even hear that TB continued to exist in Canada. They thought that TB was a disease that had already been eradicated in the Canadian scene, and they were surprised to hear that there are populations in Canada that still experience, for a number of different reasons, still experience high incidence of tuberculosis. So that was another interesting piece of information that we heard in numerous places.
Mm-hmm. Anybody else have experience with TB stigma where you are?
Hi, my name is Maria. I'm a nurse educator. I work in Vancouver with the BC CDC. So I'm actually, I mostly support actually provincial education versus our clinics. So I don't have as much, personal stories working with patients having a lived experience of stigma. But in my role supporting our teams, it's definitely been a very long-standing issue, stigma. And I completely agree with the intersectionality of it. And I guess I feel like it's been a hard thing to tackle appropriately. I feel like education has been a major strategy to try and improve the situation. But in the short term, sometimes we want to focus on the clients and providing a safe environment. We found, like, for example, having an outreach team was really helpful because, as you described, like, the stigma, like, people want privacy and confidentiality. And so when you have an outreach team, it can allow our workers to go and meet people in a safe place where they maintain that confidentiality, given that some people are living in, either in shelters, or they could be living in, small communities with many families or multi-generational families. And so try to, if someone needs their medications, finding ways to support them to take their treatment in ways that they don't feel that other people in their communities will know that they're getting treated, just helps facilitate that in the moment. But at the same time, we still want to address the larger structural issues of why they are experiencing that stigma. So I think there's a balance of trying to meet the patient where they're at, but also then address those much broader, wider issues of stigma.
Mm-hmm. That one of the things that Cynthia talked about was the piece about how, those of us who are healthcare providers or work in health and social services have our own reactions to TB. And I think that's another piece, I think, or at least in my experience, of that kind of broader stigma thing. It's, a lot of the people who are going to be interacting with someone with TB or at risk for TB or being worked up for TB, those healthcare providers may not know a lot, and we all have cultural backgrounds ourselves. Mm-hmm. So, I find even just, and there's certainly the education piece and, passing on the information things to colleagues and that, but there's also kind of a big role modeling piece. Cynthia mentioned about PPE, like tuberculosis it just gets a bit tangled up with COVID, but tuberculosis is not spread through droplets. You don't need to be wearing a gown and glove to work with somebody who's super infectious with TB. You just need an N95 mask, that's it. And even just role modeling, what's PPE to wear, and not going way overboard with it, and role modeling being comfortable going into the room with someone who has active TB and not being, super anxious about that is another thing that comes up a lot, I find, in our work in Toronto.
Yeah, Elizabeth, we sort of joke, but not really joke. It's a bit of the flinching syndrome, right? Yeah. Like somebody says something and people see our reactions as providers, right? And they watch your face, they watch your body. And when you have that little moment of, oh, like that, like people see that reaction, and they feel it really heavily when they're talking to a provider. They are reading your body language. They're looking at your eyes, like they're really watching how you're reacting, to them, and that little flinch sends a message to a person about that experience, and it can turn an experience negative. It can make an experience very negative just in a split second. And we've certainly seen in COVID with the IPAC, the PPE, that it can distance people from an interaction with their provider because people are already nervous. If they think that they have TB or COVID or HIV, people are already nervous. And so those interactions, being very calm and being very smooth, are really critically important, because they set a tone, and I would say it's even a long-term tone in terms of what that person will feel, not only in relation to that particular health issue, but it'll impact how they even see and experience the healthcare system many years down the road. So all of those things, you want to have the right gear on, but you want to wear it and put it on in a way that doesn't send a wrong message to the patient or to the client.
Innocent put a comment in the chat about stigma affecting the support systems that people have, like your own support systems, as well as impacting treatment adherence. And yeah, I totally agree. Lee, I know we have 9 minutes left, so I don't know how much more time we have to talk about this, or should we be moving on?
Yeah, maybe if anyone just has any last quick points on this discussion, and then we'll move on. Or if Cliff, you had anything to close with. Thank you so much for sharing.
No problem. I don't have like a song or a dance prepared in terms of closing, only to say thanks. It was really interesting just even participating in the call and seeing your report, because there certainly are similarities in some of the recommendations and calls to action. So it's nice to know that we're not completely off on the wrong track. We are on the right track. So it was interesting to be here and to hear that and to participate in the conversation.
For sure. Yeah, it's great to hear what everyone else is working on and to have the space to just kind of fill each other in. And if we can collaborate, then that's awesome. So on that note, and in the interest of time, I'll just open it up if anyone else on the call wants to mention any projects that they're currently working on or recent work that you'd like to just share with us or to share with the network, and we can promote it. So I'll just open it up quickly if anyone has anything to add. All right. Anything from you, Elizabeth, before I close the call?
No, I was just kind of laughing because for a lot of us, it's been like COVID nonstop for 18 months. So TB projects, a lot of TB projects I know have been kind of put to the side. And for me, it was super gratifying to have Cliff's project actually kind of hit the final report stage this summer. It was a really great boost to be kind of circling back to TB and hoping to really seize that again as COVID cases go down.
Yeah, so just looking forward, we'll continue to try to host these informal calls every 2 months or so. So if anyone on the call has a specific topic that you'd like to bring, feel free to reach out, and we can arrange that. And then we're also trying to commit to a quarterly webinar. So same thing, we'll dive into a specific topic. And if you have an idea for a webinar, reach out and we'll try to make that happen and work together. So please continue to share your upcoming events and resources that you find with us. You can email us at hello@stoptbcanada.com. And finally, if you haven't joined our directory, signed up for the newsletter, follow us on Twitter, please do so and reach out if you would like to work with us in any way in the future. So thank you to everyone who made the call today, and I hope you enjoy the rest of your week.
Thanks,
Thank you.
Cliff.